Good afternoon and welcome to SNS. The heading of today's webinar is Economic Responses and Optimal Restrictions to Mitigate Covid-19. How do optimal restrictions depend on demography, healthcare systems, and on people's behavior? What policy response is suitable for high-income countries and low-income countries, respectively? And what do we know about the effects of the policies that have been put in place in Sweden to combat the pandemic? To learn more about these issues, we have invited Kurt Mitman and Tessa, who are both associate professors at the Institute for International Economic Studies, IIES, at Stockholm University, as well as Erika Färnstrand, Damsgaard, head of macroeconomic research at the National Institute of Economic Research, Konjunkturinstitutet. This webinar is part of IIES SNS International Policy Talks, and we are very pleased that you will share your recent research results with us here today, Tessa and Kurt. My name is Ilinca Benson. I am Deputy CEO at SNS, and I will be today's moderator. We will start off with Kurt and Tessa presenting their research, after which Erika will comment on these findings. Finally, we will open up the floor for a panel discussion and also get some insights from Erika on the National Institute of Economic Research assessment of Swedish corona measures. A warm welcome to all three of you. And I would also like to welcome all of you who are watching and listening. I encourage you to join the conversation by writing questions in the Q&A function, which you can do anytime during the session. I will then pick them up during the panel discussion. Or if you prefer to pose your question directly, please indicate this with the raise hand function during the panel discussion. Now, please let me introduce Kurt Mitman. Kurt, you and your colleagues have applied an integrated economic and epidemiological approach and used empirical data on county level from the US in order to analyze policies for managing the COVID pandemic. Please tell us more about your research and results.
Well, thank you very much, Ilinca, for inviting me to present my research and to be a part of the panel. Really looking forward to the discussion. So this is based on joint work that I've done with Marcoeconomic, Doug Hanley, and Daniel Kollner. So what we really wanted to do is thinking about putting together an integrated model where we can evaluate both the economic and the health aspects of the crisis. And that's really what we kind of set out to do. And then we wanted to discipline that model with data to be able to talk about empirically informed trade-offs. So, like I said, we wanted to build and estimate a model where we allow there to be feedback between how people go out into the marketplace and how the virus spreads. Then we're going to use that to estimate it on US data because we had that kind of readily available at a very granular level. And then we wanted to study what are called non-pharmaceutical interventions, in English, or NPIs. So these are anything that you use to combat the virus that's not medicine or vaccines. And so what we're going to exploit is the fact that different locations, kind of different counties in the US, there's over 3,000 of them, rolled out different policies at different times. And so we can use that to try to identify the effects of these interventions. And then we can use the model, once we have the parameters, to run experiments where we ask kind of what happens, what are the trade-offs, what could we achieve, in terms of trade-offs between wealth and health. So I just want to give you a sense of what kind of the data looks like, and so why we see that there really is this two-way interaction between the economy and the virus. So the data sets that we're going to use essentially to discipline the model are going to be these kind of summarized by these four panels. So we kind of look at the upper left here. This is the reported cases in the county. The red line here shows you the mean, the blue line is the median, and the other lines show you different percentiles of the distribution. So how that evolved over time and across space. Then we look at reported deaths. We also have a measure of economic activity. And this is basically based on tracking the cell phones of 46 million people. So looking at, did you go to the store? Did you go to a restaurant? Looking at how many visits people make in response. And this is going to be relative to 100, which was kind of before the pandemic. And then we have a measure of output, and this is going to be hours worked. So we have a panel of about 50,000 businesses where we see every day the number of hours that people actually worked at those businesses. So we can link, did you go to the store? And if you went to the store, then how many hours did someone work in that store? And so what you can see, and in particular, if you kind of look at the reaction, when we had the big increase in deaths in the United States, a big drop in economic activity and output. Obviously, different places responded differentially, but there was kind of a big link between the spread of the virus and also the change in economic activity. Of course, policies were also changing, so I'm not going to say that this is just people changing their behavior, but then as policies relaxed, we had kind of this resurgence in the summer, and now we've seen kind of this third wave coming in the US, and kind of more of like a second wave that we saw in Sweden. So I'm going to argue for you, and without going into details, that this isn't just about the MPIs. So the figure here I'm showing you is kind of the three main MPIs that were rolled out in the US were about the closure of schools, about closing restaurants, either closing them entirely or closing them to indoor dining. So a lot of places allowed outdoor dining, but they did not allow indoor dining. And then these kind of stay-at-home orders, which is where essentially all retail services and restaurants were closed. And so this is kind of to show you the timing and kind of what percentage of the US population was affected by these different orders. So kind of schools closed very quickly, restaurants also closed very quickly, stay-at-home orders evolved kind of more slowly over time and across space. Now, the idea is that we aren't going to assume that we know how these orders are going to affect how much you go out into the marketplace, right? A stay-at-home order, things like pharmacies and grocery stores were still open. So how much people chose to still go to them is kind of an open question. And so the idea is that in each county, we'll feed in the time series of the policy path, and then we can estimate how much that policy actually caused people to reduce their behavior kind of above and beyond what they would have done just because they were afraid of the virus. So to give you a sense of where our model contrasts with the standard model, so in the basic model that epidemiologists use is called this SIR, so susceptible, infected, recovered. So susceptible means you haven't been infected, infected means you're currently an active infection, and recovered means that you are no longer contagious. So it could also include people that are dead. And this picture here is kind of, I'm making fun maybe a little bit of the model, but there people make no decisions. Basically, infected people and susceptible people interact. The virus rages, just like the people here, you don't care at all that there's a virus going on. You do everything you normally do, and you get these kind of very dire predictions from that model. This is just to give you, I want you to focus here on the left graph. This kind of shows the dynamics of that model of what would happen with COVID. Each of these dots here represent 1 week. So this would say that kind of within a month, 25% of the population is currently infected, and this whole thing is over in a couple months. Obviously, that's not what we saw happen because it's been now almost a year since this happened, and that model just is rejected by what we see in the data. So what we do is that essentially we build in the fact that people have economic needs. People, you want to go out to the store because you want to buy things, you want to go to a restaurant, you have economic needs, but you understand that if you go out of your home, that you have a risk of contracting the infection. You understand that there's some cost to you. And here we take kind of a broad view of the cost, that it's not just you might die, but you might become ill, that you could have long-term illness, that there's this cost of infection that everyone faces. And then you decide, okay, I know what the costs are. I know that there are infected people out there. What do I do? Do I want to have a fika? The salmon look really delicious. Do I want to go to ICA? Maybe you say, okay, I can wait a little bit longer. I don't need the toilet paper, but I really, the semla only around for 1 more week. If I don't do it now, I have to wait a whole nother year. And you ultimately choose, I do this activity, but I don't do that activity to balance the risk reward that you have. And then obviously, if you go to the store less, then the store is going to, in the end, hire less people because they're not going to need as many people to work there. And so when people choose not to go to the marketplace, that's also going to lower output. And this is what we're going to discipline. Again, like I said, we have this data. We know how many people are infected, how many people are dying. how many people are going to stores, how many people the stores are employing, and that's where we're going to tie it all together. And what you get, this is just kind of an example of what I showed before. So this was basically the SIR model. This parameter here is supposed to mean kind of how costly it is to you in order to get the virus. And in the model, when you get that, what you get is that you never get this peak where all of a sudden 25% of the people are infected at one time. The peak here, this stylized, is much lower, and the dynamics are much more protracted, so that the pandemic plays out over a longer period of time because people optimally stay at home. They don't interact as much in the marketplace, and so the spread of the virus is much slower. Okay, this is just to show you that when we estimate the model, obviously, we were trying to match 3,000 counties daily, over the course of a year. So we're not going to fit everything perfectly, but we do a good job of kind of matching the model to the data. We also do well kind of spatially. This is just to pick kind of two states. I mean, we're estimating the model at the county level, but just to show you that, we're not just matching averages, we're getting things pretty well in the cross section. And kind of these lines that I'm showing that we have here, these kind of show you how the different MPIs are turned on and turned off, which are kind of fed in to discipline how they interact. So we kind of see when an MPI turns on or off, how does activity and output change? And that kind of pins down what the effect of that policy is. Okay, so this is now we have the model, it's estimated, we have parameters, we can start talking about, well, what could we do? So with MPIs, what these graphs are, what we call a pandemic possibility frontier. So this kind of shows you the trade-off kind of over a 1 month horizon, or over a 1 year horizon between your output loss, so how much kind of economic output do you lose, versus what the average number of daily deaths per million. So you could multiply this number by 10 for the daily deaths for Sweden. And so if you kind of look at this panel, you can see that, and the different colors shows kind of how strong of a lockdown you are. So kind of the very light blue, that's like you just shut everything, people can't leave their homes, maybe more kind of Wuhan style. And I just kind of showed you here what our estimated values for schools and restaurants are. So you can see that, as you start to kind of from this direction, as you start to lock down, you very quickly start to gain lives. So fewer people are dying, whereas the loss in economic output is relatively small. But then you kind of reach this inflection point where beyond that, you're not getting much in terms of health, but you're losing lots of output. So maybe some point like here is more of the sweet spot in terms of the lockdown versus health. But I mean, that's just kind of showing you the trade-offs. So here what we did, and this is kind of a looking back of, if you knew that a vaccine was going to arrive in 1 year, which is kind of what ended up happening, what should you have done? And essentially what this says is that, you should have locked down kind of relatively early to get the virus under control, so that you kind of had very low numbers of cases, then had kind of a mild lockdown. This kind of corresponds to something like closing restaurants. And you held kind of us there at that level where you had a replication rate around 1. So there's kind of constant number of cases and deaths. And then finally, as the vaccine starts to roll out, then you can start to open up again. That was kind of what the model says. If the policymaker weighs kind of the private cost of getting the infection with the as people value it. Now I should say this is like with hindsight. So we know that the vaccine will arrive in 1 year. What should we do? If in our model it takes more than 3 years for a vaccine to arrive, then kind of not imposing lockdowns is optimal, because you just, the costs of keeping people locked down for that long are too high. And so it's better just to let the people respond to the virus with how they kind of optimally choose to pull back. And that's kind of what the optimal thing is. So, last year, if you thought it was going to take more than 3 years, then it would make sense not to lock down. I think that I'm basically out of time, so I will skip that one other discussion. But essentially what we did here is that we've built an economic epidemiological model to capture this two-way interaction between economic activity and the spread of the virus. The estimated model says that there's significant mitigation even absent policy, so people cut back on activity even if you don't lock them down. And so this kind of highlights the need for having this type of model. Lockdowns can effectively lower the spread of the virus, but there is a cost. And that was what those curves I showed you in the PPFs are. And lockdowns we found are desirable kind of under two conditions. One, the second one I didn't get a chance to talk about, but the first one is that if the vaccine or some kind of cure would arrive in 2 to 3 years, so now it has arrived, then it does make sense to get the virus under control, so that you can kind of mitigate these unnecessary deaths when you have the vaccine kind of in sight. So I think that I will stop here. So thank you very much.
Thank you very much, Kurt, for that. It was very illustrative, I think. And I would like to do some follow-up questions right now on your presentation. And the first question that springs to mind is that if you have this result that that people sort of change their behavior in order to contain the virus or not get infected even without lockdowns, don't you have the sort of economic cost that comes with this change of behavior? I mean, you say lockdown costs, but if people do things voluntarily, then the economic cost should be there anyway.
Yes, yeah. So that's, if I just can look back at this, show you this slide here on this trade-off. So this is with no lockdown. So even with no lockdown, there is a significant economic cost. So that even if you just, you say, I'm not going to do anything, people are afraid and they're going to cut back. And so there's no way to kind of achieve full output when the virus is spreading and people are afraid of it. But I guess what we kind of see here is that there is a region where it seems like you can save a lot of lives with minimal additional economic cost.
Right. Thank you. We also have one question from the audience that I would like to take now. It's from Ann Holt Ranalet, and it goes like this. How does your model account for the availability of health services in the form of hospitalization capacity and intensive care?
Yeah, so in the baseline model, we don't have that in. We have a version of the model where we add that. And that makes the response stronger. So as you get close to having the hospital capacity, it's essentially the cost of getting infected goes up because you're more likely to have a severe reaction. And so then you get this region where people at first are kind of they're mitigating a little bit, but then as they see that the hospitals get full, the cost goes up, and so people cut back more. So that kind of flattens the curve even more because it makes people more afraid. But the original estimation, we didn't have kind of real-time county level, hospital level data. So that's something that we've kind of worked on for the robustness analysis.
Okay, thank you. And in light of the results from your study and the conclusions that you draw, what are your reflections regarding the Swedish corona strategy?
Yeah, so I think, going back to last winter and spring, I think that the kind of cautious approach that Sweden took was prudent. I mean, given that, before now, the earliest vaccine development we had is 4 years. I mean, it seems like if you kind of thought that was the timeline, then not locking down was optimal. I think there were some, protecting people in old care homes, I think is kind of a separate question that we can't fully address in our setup. So I think that seemed like a prudent course of action. Of course, now these results we have about the availability of the vaccine, it would seem like you could save lives at not much additional cost by kind of trying to lock down to get the virus under control.
Okay, thank you. We have time for one more question from the audience, from Helena Svaleryd. How do you rank the different measures in terms of strictness?
So in our estimation, what we find is that kind of these stay-at-home orders are the strictest. Then the closing of the restaurants are the next strict, and then closing of the schools is the least strict. And I should be clear, the closing of the schools, we don't count activity of going to school. This is essentially what the impact of parents kind of going out of closing the school. So that's kind of at least in our data, the relative estimated strictness of those. So
closing school is less strict than closing restaurants?
That's at least what we found. But I guess it's a little bit tricky because I guess, schools are closed 3 months of the year anyway. So, I think it's a little bit hard, but that's, again, also I should be clear that the data of activity, this is kind of going out to places. And so restaurants are a big component of the measures of places that people go. So
Right. Okay, thank you very much, Kurt, and we will see you again in the panel discussion. And now I would like to introduce Tessa Bowl to you. Tessa, your paper takes as a point of departure the worries that have been expressed by development economists about the COVID policies implemented by governments in poorer countries. And together with your colleagues, you explore how optimal government policy to combat the coronavirus differs between countries depending on demography, comorbidities, the healthcare systems, and also the prosperity level of the country, with focus on developing countries. So please tell us more about your research.
Thank you very much for inviting me and for organizing this. It's a really interesting panel. And I have to say, despite Kurt and me sitting at the same place, it's really interesting to hear about Kurt's work on this, which I didn't know so well before. And as you'll see, quite a bit of overlap here in the approaches that we're taking. So yes, as the coronavirus hit last year, it started off in China, of course, and then kind of went quickly to rich countries first. But it was very clear to us, who's sort of a group of development economists, that it would come into everybody else. It would, of course, make its way to developing countries. And so this group here, together with Tilman von Carnap, Ingvild Almos, Selene Ghisolfi, and Justin Sandifer, we, like many other development economists, started thinking about, what would be the particular challenges of COVID-19 in developing countries or in low-income countries, given that, of course, there are many striking differences between high-income countries and low-income countries. So one thing that was not different at the start of the epidemic was how strongly countries reacted. So this is a graph from the now, I think, quite famous Oxford Blavatnik School Stringency Index. So it just kind of, 100% here is full lockdown and then 0% is doing nothing. And this kind of shows for, we've picked here out United States, Uganda, but high income, low income countries in general, how strict their measures were throughout the course of the pandemic. And you can see here that certainly in the beginning, they were very strict and kind of remained high and strict with a slightly downward trend almost everywhere. So, given how hugely different Uganda is from the United States, there is not so much difference here in how these countries responded to the epidemic. So our question was then, this seems to be a sort of one-size-fits-all policy, but what would the optimal policy most likely look like? And it's, of course, affected by both disease risk and poverty. So those are two really important inputs into figuring out what an optimal policy is here. And then another question we wanted to dig into a little bit. I mean, how is the value of a statistical life, evaluation of life, actually, how does that vary across country, and can that explain the responses that countries had? So the first step we took was to think more about this disease risk. So if you think back, in March, April, we actually didn't know very much about it. But some of the things we did know is that it seemed to really affect older people much more severely and people with underlying morbidities or comorbidities. And taking that into account, we then kind of estimated for all countries in the world, actually, with a specific focus on low-income countries, given these parameters, what their mortality risk or infection fatality risk would be from COVID. And you can see here, so the darker, the higher your risk, and the lighter, the lower your risk. So actually, low-income countries actually have a much lower disease risk because they are so much younger. So even though at given age, the population is slightly less healthy and that somewhat heightens your risk, really it's like this demographic difference that has this huge impact. So not just our study, but many others suggest that the mortality risk from COVID is really of an order of magnitude lower in low-income countries than in high-income countries. So that's kind of the first important input when you want to make these kind of trade-offs between how you let the pandemic spread and the economy. So the second input is that you need a model that combines kind of an epidemic and an economy. And so this is very similar to what Kurt just told you. So in particular, we kind of build on recent macro and epidemic models where you have this feedback loop between infection levels, which affect economic decisions, but then economic decisions also affect infection levels. So the key mechanisms here are, just as Kurt told you, so the more agents work and consume, the more likely they get infected. And because getting infected is costly, both because you're sick or because you might die, agents actually reduce the activity even when the government does nothing. When infections are high. And so what I mean is they reduce activity compared to business as usual, which is what a sort of pure epidemiological model would assume. However, they don't do this quite enough, because I only care about, or at least the model assumes, I only care about reducing my own risk of infection, but I don't think about that also affects others. So there is some room for government policy here to slow the pandemic by discouraging work and consumption even more. And then the question is, what is this optimal containment rate, i.e. the one that balances deaths and lower consumption? And so where the cost of death here in all these models, to start with, is kind of the foregone utility of life. It's just what you would have earned if you'd stayed alive. So we take this kind of model and kind of examine, what the different inputs do in terms of the optimal policy. So here comparing Uganda and the United States. And so what are the starkest differences between these two countries? Well, Uganda is much, much poorer than the United States. It's actually close to the poverty line, such that subsistence levels actually bind. In the US, well, but for most people, if you reduce your consumption, you're not going to be in danger of starving. But in Uganda, you actually are. You're close to the subsistence level. And the other big difference is, of course, that COVID is much less risky in Uganda. And so on the basis of that, we then compare the optimal policy in these two settings. In a similar model to Kurt's, although I'm sure his is much more sophisticated than ours, but we're trying to make a simpler point here. So this is kind of how the epidemic would pan out if you only have an epidemiological model and you leave everything business as usual. So, the government doesn't do anything, and economic agents, we are assumed to do nothing either. So then, here with the kind of numbers we have, this is like 60% of the population would be infected by COVID by the end of this. So then, of course, however, this is now for the US, as Kurt has told you, and as this model also predicts, agents will not continue with business as usual, but rather they will reduce their consumption, they will work less. That has economic costs, but it also reduces the number of total infected and the number of deaths. As I said, it's not quite the optimal amount of reduction. The government would like to do more here. And so the government, when it puts in the optimal policy, aggregate consumption would be reduced even more. But you see here, the number of deaths is reduced even more relative to, if we're just left to our own devices and decide to go less to ICA or fika less. When the government can also make policy, they would want to reduce the total number of people who ever got infected by even more. But how does this look now when we switch to a low-income country, to Uganda? So in Uganda, actually, first of all, this is this dotted line here, as I said, because of the lower death risk, there are many fewer deaths, even if nobody does anything. So that's the good news. Then, however, because people are already so poor, this kind of endogenous response by economic agents is actually fairly weak. So they only reduce consumption slightly, because reducing consumption is very costly if you're very poor. And similarly, the optimal government policy, yes, it's a stronger response than what households themselves do, but it's way less strong than what the US government would do. And so as a consequence, actually, the difference between, the number of deaths you would have and what happens if the government steps in and if agents re-optimize is actually very small. Okay. So just to say, where does this come from? So here in the first column, that's what the US would want to do. So their optimal policy would be to reduce consumption by 20%. And that would mean that they would reduce deaths relative to this epidemiological model by 30%. So then you could think, okay, if you had the US economy, but a much lower death rate, like the Ugandan one, well, you'd be down to reducing the economy by 12%, but also you only reduce deaths by 20% relative to an unchecked epidemic. Similarly, you can think, okay, what about if, mortality was as big as in the US, but you're as poor as Uganda, gives you about the same. So when you combine this, much less deadly and poor, you're basically down to a much more muted response. So you only want to contract the economy a little bit, about 7%, and equally, you only want to reduce deaths by about 10% relative to an unchecked epidemic. Here, then we also put in this kind of subsistence constraint, and you get even more muted response. Here, in contrast, in column 7, that's actually a little bit what Uganda has done. I mean, sort of imposed US policy with quite strict lockdowns. And you see that compared to their optimal policy here in column 5, you get the trade-off quite wrong in some ways with the deaths and consumption responses. So I see Ilinca already, and I will just come to the end here. So one thing I did want to talk about briefly is, of course, a really important input that we discussed not so much is kind of a value of a life saved in all these models. And we have kind of good reference values that are actually used for high income countries. So for the US, it's $10 million. Sweden, it's $5 million. But for low-income countries, we actually have very little data. So it is kind of an important input one should think about. And I'll just leave you with a number of possibilities here. So we could say it's the same everywhere. We could say that. Clearly, that doesn't seem to reflect our decisions. It could be related to what one produces. So just scale it by GDP per capita. You could say, well, do that less so as people become poorer. So relative to your GDP, your life is worth more as you get poorer. Or you could think about, since this is somehow supposed to be about preferences, it should be related to what government is willing to spend on saving a life. So you could think about scaling it with health expenditures, share of GDP, which is what we do here, $31,000 a year that gives you. Or you could scale it by what people are actually willing to spend on saving their life. And there are a number of interesting experiments on that. I should say this tends to give the lowest valuations of life. And so here the last slide just shows you, here's always the optimal contraction and consumption. So, going from 0 to 30%, and the number of deaths or share of deaths you want to reduce. And you see here that really this valuation of a statistical life is really important in terms of the kind of optimal policy. So this is like the optimal policy for Uganda here, all these blue dots, given different valuations of life. So just to give you also the sensitivity there, very sensitive to this particular parameter, but always lower than what a high income country would have done. So thank you very much. I'll stop here.
Thank you, Tessa. And I would like to start off maybe where you finished. If you could elaborate a little more on possible explanation for why many developing countries, such as Uganda, but also a lot of other countries, have chosen this stricter containment policies, even though they maybe shouldn't have.
Can I also share my screen still? Because I think the first slide is helpful there. I actually asked my co-author to update it today with the most recent. Can I do something? No, okay, I guess we have to go through again. There we have it. So first of all, and it's partly because time is tight, what I should say, I mean, there are two reasons for having a very strict lockdown, right? One is because something neither Kurt nor I had time to go into is to sort of avoid this epidemic overshoot. So you're going to have an epidemic, but you want to make sure that absolutely not an additional person above this herd immunity threshold ever gets infected. And so, the epidemic is going to happen, but you're restricting behavior so that you kind of have the smallest epidemic possible. The other reason for having a lockdown is, of course, because you want to make sure that the epidemic never happens. So I think in the beginning, when you still have that chance, as New Zealand has successfully done, then that, of course, is kind of a sensible policy measure if you manage to really avoid the epidemic altogether. However, as sort of time passes on, then of course that is not going to happen. And so then I think these measures are they are quite strict given kind of the economic situation. So I think a little bit is that to some extent we did start off with epidemiological models where there wasn't necessarily this trade-off between, what your model would tell you was just to do with avoid as many deaths as possible. So that's one of the reasons. The other thing is, of course, that you're acting under enormous uncertainty. So even though the patterns we observed already quite early on would have said mortality is not going to be so high in low-income countries, of course, there's also much you don't know. So I think those are reasons, but I think partly it is because we at the time weren't so good at formulating these trade-offs as we are now. And maybe you want to ask me this later, but we can talk a little bit about the time trend, at least here, of the policy as it goes on.
Thank you. And we have some more audience questions, but I will save them for the final discussion in order to bring Erika in on the screen, not the stage, unfortunately. Erika, you have led, as I said maybe in the beginning, the National Institute of Economics research work to assess the economic consequences of the COVID pandemic in Sweden, as well as also to assess the effects of the measures taken to fight it here in Sweden. So now we're very interested to listen to your comments to Kurt's and Tessa's research. Please, Erika.
Thank you. Thank you for inviting me to give comments on these two very interesting papers. So I'll start with the paper Economics and Epidemics presented by Kurt. And first I'll give you a short summary of the paper and then I'll ask a couple of questions. So what the authors do in this paper is they set up a model which includes both the spread of COVID-19 and the economy, and then they estimate it using US data. And since they have such a rich data set, they can estimate the effects of restrictions, such as stay-at-home orders. And then they take the estimated model and analyze what the optimal policy is, depending on when a vaccine arrives. So can the results be important for policy? Yes, definitely. To find the optimal policy, we must have models that integrate epidemiology and the economy. And one reason is that many policy measures to reduce the spread of the virus, they aim at reducing social interactions. Fewer social interactions implies lower transmission of the virus, but also lower consumption and fewer hours worked. So there is this trade-off between the positive health effects and the negative effects on the economy. And that is something these models can capture. And this paper can tell us under what conditions restrictive policies such as stay-at-home orders should be used. So to my questions, we know that the health risks are much greater for older people. So optimally, we would like to reduce their exposure to the virus more. So if you would include different age groups in the model, how would that affect your results? And the second question, in the paper, you suggest that if the transmission of the virus is reduced to a very low level, then testing and tracing can be used. So my question is, can testing and tracing only play a role when transmission of the virus is very low? In addition, this model is estimated on US data. If one wants to apply the results to a different country, for example, Sweden, what are the caveats? What is it that we need to bear in mind? And my last question, we know that COVID-19 and the restrictions to reduce the spread of COVID-19 can increase inequality, both in health and income. So if that could be taken into account in your model, what would the optimal policy be? Would it be to exempt some workers from restrictions? Would it be to use fiscal policy to increase transfers to households? Or would it be something else? Okay, now to the second paper, the macroeconomics of pandemics in developing countries, presented by Tessa. So what the authors do in this paper is they take a model which includes the pandemic and the economy, and then they analyze how the optimal policy to reduce the spread of COVID-19 depends on two factors, the country's income level and the share of people dying from infection if they get infected. And the reason why the income level is important is that if income is low and consumption is low, it becomes more costly to reduce it using restrictions. And if the share of people dying from infection is low, for example, because the country has a young population, then the negative health effects of COVID-19 are not as large. So they calibrate this model first to the US and then to Uganda, and they find that optimal policy is much less restrictive in Uganda, relative to the US. So can these results be important for policy? Yes, definitely. The paper shows that each country has its own optimal level of restrictions to reduce the spread of COVID-19. So each country should have its own strategy in fighting COVID-19. And if developing countries were to just adopt rich countries' policies, it can lead to excessive restrictions, hurting those already in poverty. So to my questions. Well, first, we know that developing countries tend to have large informal sectors. If that could be included in the model, how would it affect your results? And the second question is, you propose in the paper that the high support for lockdowns in developing countries can come from people overestimating the risk of dying. So my question is, what would then be the policy implication? Should there be public campaigns giving people the accurate information about the risks? And my third question is, if vaccination were to take longer in developing countries compared to richer countries, how would that affect your results? And the last question, we know that COVID-19 and restrictions to reduce the spread of COVID-19 can increase inequality. So if that could be taken into account in your model, what would the optimal policy be? Thank you.
So, thank you very much, Erika. Now I would like to invite all panelists into the screen. And you have this list of very interesting questions from Erika, and also some questions from the audience. So I propose that I will start by trying to put some of Erika's questions to you, and then we can move on from that if you want to pick any question especially. But I think, Kurt, if we start with you, what would how would it affect the results if you had been able to include age groups into your model?
You know, that's a very interesting question, and I think this also kind of highlights a kind of a contrast or a point that ended at Tessa's part. So in our model, we don't take a VSL, or we kind of directly estimate what the cost of the infection is. So we say we see activity and we see what happens, and then we find the parameter that gets the activity to match what we see with the spread of the virus. So that kind of comes out from what people tell us how they feel about it. And so with different age groups, what we would probably have is that old people would be, I would suspect, you know, we would find that they have a very high cost of the virus, and younger people have a lower cost, so that we would see more cutting back of activity of the old than of the young. And so then, you know, you might think about having, you know, even age targeted policies, so that the policies really are affecting the young more than the old, because the old are already cutting back. And there was a very nice paper, I forget the authors now, they kind of compared Sweden and Denmark early on in the crisis. And if, you know, Denmark had locked down and Sweden hadn't. And so the consumption of the young in Sweden, you know, did not fall relative to those in Denmark. So Denmark, they come by a lot. But in Sweden, the consumption of the old fell by more in Sweden than in Denmark. So even though the old were locked down in Denmark, the non-lockdown Swedes cut it by more. So we can see in the data that would kind of come out of the model. And so, you know, that again gives you kind of more, you know, it gives you more incentive to protect the old because they have this higher cost. And so that would kind of tell you right away that you should do things to try to isolate the old from the young. You know, even policies like, you know, having hours at the supermarket where maybe only old could go. I mean, you know, ways that you could try to target policies better.
Okay, thank you. And if I move on to you, Tessa, the question that Erika's first question about including informal sectors in your model, since these tend to be rather large in developing countries, what would that result in?
So in our model, we don't distinguish between formal and informal sector. So it's a little bit, there is a paper that looks at that specifically. And then of course the question is what is it about the informal sector that you want to model here? So the approach that they take is just to say, the government has sort of no jurisdiction in the informal sector. So if they want to shut down the economy, they can, but they cannot shut down the informal sector. And so again, it kind of plays a little bit into this. Well, if essentially the government can do very little, then that also means their optimal policy is even more muted. If yeah, so that's kind of the answer here. I haven't thought it through fully, but I think that's my sense, because in the end they're going to be much less effective. And then Kurt, I know you've done a little bit of work on this. I mean, it's not the case that then you want to have even more severe restrictions on the small piece of the economy that you can control, because it's just impossible with a pandemic. So.
I would like to continue with a question from the audience, and I would like to start to ask it to you, Erika, and maybe you can fill in, Kurt and Tessa. It's from Jonas Eriksson, and it goes like this. The Nordic countries, except for Sweden, have all adopted more suppression-like strategies. They have all been much more successful than Sweden when it comes to saving life. Still, the effects on their economies don't seem to be much different from Sweden. Would you like to comment on this, Erika, from your assessment report?
Yes, so I can definitely comment on the economic effects. And what one has to bear in mind is that Sweden, as well as the other Nordic countries, are small open economies. So that means that the effect of COVID-19 on the Swedish economy comes mostly from abroad. So the spread of COVID-19 in countries we trade with and the measures taken to reduce the spread of COVID-19 in the countries we trade with. And then, of course, we have the additional effects of COVID-19 and the measures taken domestically in Sweden. But a large part of the effect on the Swedish economy actually came from abroad.
Okay, thank you. Maybe we will be content with. Oh, yeah, sure.
Can I say one thing? No, I just, because this, I think people they see big numbers and they say that they look kind of about the same. And so they say that these things are the same. Because I remember I saw early numbers that maybe in Denmark, consumption fell, 24%, and in Sweden it fell 21%. So that's the same. If you think about like in the United States, the Great Recession, which was the worst recession since the Great Depression, consumption fell 3%. So the difference between Denmark and Sweden is the worst recession the United States had in 50 years. Which, okay, 21, 24, it sounds like those are the same, but normally that is a huge deal, 3% drop in consumption. So I don't think that just, because the numbers look the same, I mean, normally consumption doesn't fall in recessions. So, percentage points in consumption is a really big deal from welfare and economist point of view. So I just wanted to say that you should be careful about, the numbers are big, but the differences are also going to be very big.
Thank you. And Tessa, maybe this is also for you, Kurt, but it's one of Erika's questions for you, Tessa, about sort of the importance of information and also the government's possibility and maybe duty to inform the people about the risks and also the higher risk and the lower risk and maybe information as a policy. What do you have to say about that?
I think it is hugely important. I mean, that partly motivated us to work on these infection fatality rates first, because when we started off a year ago, I read a lot of places it's 5%, yeah, so 1 in 20, and these were case fatality rates, but nevertheless, so I think that's always hugely important. Having said, I mean, I'm not sure that any government in the world is really doing this very much. But, I mean, we are getting these kind of this advice, like wash your hands and all this, and I think that's correct to give that advice. But I think for a policymaker, at least, I think it's hugely important to have good numbers here. And in preparing for this, just this morning, I was trying. I have sort of taken a little bit of a break from COVID research, but I was trying to get a sense of, what is the situation now in low-income countries, and it was just still really difficult, to make sense of the data from there. So on the one hand, we have studies that show, seroprevalence rates of 5% of the population, which means they've had actually pandemics. That's what Stockholm had, like in, I don't know, at some point before the summer. And then very low death numbers, but then it's really hard to know what is reliable here. So I think that for sure is always say this, we need better data, but this is really an example of why.
And I mean, as you started off, you said something about this one size fits all sort of recommendation from, do you think that the World Health Organization, have they been sort of detailed enough in spelling out which groups are more vulnerable to get infected? And I mean, this is a question for all of you three. How much have the sort of international debate been one size fits all?
So first about the vulnerabilities. So the World Health Organization actually came out with a report quite early on where they estimated much lower deaths in sub-Saharan Africa, and they have been so that's kind of been their that's sort of been what they've put out. Having said that, I actually don't exactly know. I'm not sure that they've therefore adjusted their advice to how you should deal with this. It seems to me it's always lockdown and test and trace and yeah.
Okay, and Erika was also asking both of you about the inequality dimension and the effects of inequality, and also I would like to add to that the question from the audience that is not exactly the same, of course, it's rather different, but it's still another dimension, and that is if you ever consider to bring in the losses of life resulting from economic downturn into your models. So Kurt, would you like to start on this, both on the inequality and on the sort of longer term loss of life?
Yeah, no, so I think in terms of the economic inequality, I mean, one thing that's abundantly clear is that the people that are most exposed to closures and losing their jobs as a result of COVID are people with lower incomes to begin with. And so, it's kind of crucial for the social safety net to be able to provide those people support, especially when, businesses are being closed through no fault of their own. I mean, it doesn't seem very fair that, the government tells you can't work and then you get no salary. So I think, European countries have done better about that through kind of short-time work and other policies that the US hasn't been as good with. So I think certainly, if you want to implement restrictions, it's very important to understand who those people impact. And it typically is people who are much more economically vulnerable. And so that, transfers and fiscal policy need to be designed to support them. And also particularly it's not maybe as much of a problem in Europe and the US, those people also tend to be more afraid of losing their jobs. So they kind of providing protection that if people are sick, that they can stay home and not, induce the spread, I think is something important that needs to be done. In terms of looking at the longer run costs of these policies, I think that's something that we're just kind of now starting to understand. I mean, I think even from our data, it looks like the effectiveness of policy is probably changing over time. I mean, being locked down for a month, it's kind of not so bad. Being locked down for 12 months, I think it's, there might be some nonlinearities there that we need to kind of understand better. And then also I saw there was a question in the chat about, closing schools. Obviously, closing schools for a few weeks is probably not so bad. Closing schools for a year, again, would also then impact people who don't have the means to kind of provide that at home. So I think we do need to do a lot more to understand the longer run impacts of these types of interventions. And, I think we don't really have quite the data yet to understand both on kind of the psychological health and the schooling impacts, but that's certainly an important caveat that we can't estimate yet.
Tessa, would you like to continue?
Yeah, just to echo this, and then in some sense, it's even more severe in low-income countries, that when you have school closures, and the other big concern is in low-income countries is this crowd out of other health-seeking behavior. So you miss vaccinations, you miss important preventative care, antenatal, et cetera, that really have large costs. So I haven't personally worked on this, but there's certainly a lot of people worrying about this and trying to estimate this, what is lost sort of in terms of numbers of people who don't get vaccinated, et cetera. And it's those kind of basic health intervention and basic education that also then have an impact on inequality, would lower inequality if they happen.
Thank you. I would like to turn to you, Erika, and also turn the attention to your report on Sweden. And I would like to ask you, what do you think are the most important takeaways from your report for Swedish policymakers going forward?
Yes, so in our report, we analyzed 16 different measures implemented in Sweden to reduce the spread of COVID-19. And we find that for most of them, there is this trade-off between positive health effects by lowering the transmission of the virus and negative macroeconomic effects. But for some of these measures, there is really no trade-off because there aren't any negative macroeconomic effects. So I think the main takeaway from our report is that there are many measures that can be implemented to reduce the spread of COVID-19, and they differ, both in terms of their macroeconomic effects and also in terms of their negative health effects. For example, depression resulting from less social interaction. And that means that when policymakers have decided how much they want to reduce the spread of COVID-19, they should carefully choose which measures to implement in order to achieve that reduction.
Thank you. And I would like to go on to the questions that you posed, Erika, to Kurt. If you would do this kind of modeling on Swedish data, what would be the caveats?
Yeah, so I mean, we're going to try to do that. Obviously, I think some of the things to think about is we for each location we kind of estimate how transmissible the virus is, which would kind of depend on cities that are very dense, maybe it transmits more than in cities that are not, so that we would have to adjust that. So I think that's kind of one thing to take into account. Also, I mean, the structure of households, I mean, there's a lot more kind of single person households in Sweden. So kind of measures like quarantining at home would be much more effective than when you have 6 people in a house. So I think that's something to keep in mind. I think also, I mean, as a foreigner living in Sweden, I think kind of more practical implementation of letting immigrants understand what recommendations are, because in the US, CDC recommends something, most people ignore it, whereas I think here there's kind of a culture of recommendation is almost like a rule. But when you have, I don't know, 10% of the population foreign born that don't understand that, it could be good to communicate to them more forcefully what you want to do. So I think that's something to think about for mandatory restrictions versus recommendations as policy tools for Sweden.
Thank you. And using this integrated epidemiologic and economic model, is this a new way of working for this pandemic, or has it been used earlier when it comes to epidemiology, epidemics, or also other policy areas, Tessa or Kurt?
I leave this to Kurt, but I think that just explosion and research around this has been just absolutely unique, and economists really getting interested in this. And most economists now a SIR model, and they now know a SIR model, and they certainly didn't, I would say, 2 years ago. Is that fair?
Yeah. Yeah, no, we were just kind of doing a literature review on this, and I think so. There were models before, particularly about HIV/AIDS, where people are making kind of optimal decisions about, do I have sex or not? There's this risk, but they were mainly focused on the health and life outcomes, because HIV/AIDS. I mean, I guess in sub-Saharan Africa, when you have kind of this huge number of people infected, they can affect the economy, but most of these choices kind of don't directly impact the economy, and so that hadn't been put together until this pandemic.
Okay, thank you very much. I think that will be the closing remark, and I would really like to thank you, Kurt and Tessa, very much for presenting your finding, and also Erika for your super insightful questions and also sort of summarizing of these papers. It's been very interesting to have this discussion with you. And I would like to say both to you and to all you in the audience that look at this as sort of the start of a conversation. I'm sure that you can find each other and continue the dialogue. And before we say goodbye, I would like to draw your attention to the next seminar in our series together with the IIES, which is on February the 15th, and which will be on a related topic, We will then discuss how the restrictions to contain the coronavirus have been experienced and adhered to here in Sweden. So we will sort of continue this conversation from another perspective. So very welcome back then. You can read more about that webinar and also register for it on our website.